are very fortunate tonight to have Dr. Anna Parks with us again. She's been a fan favorite. So Dr. Parks, Anna, thank you for joining us. I want to remind everybody that we are not here to give medical advice. This is for informational purposes only. It is being recorded, so there will be a replay of it as well. But everybody is different and unique, and so please, while we will answer questions later, just want to make sure that you should be speaking directly to your doctor or whomever it is that treats you for your blood clotting situation. So I just want to introduce Dr. Parks. Anna is sorry, we're on first name basis here at PEP, so we're going to go with Anna. Anna is a physician investigator applying aging research methods to improve the care of older adults with non-malignant hematologic disease. She's an assistant professor and director of thrombosis in the Division of Hematology and Hematologic Malignancies, and a Center on Aging faculty member, which we're going to talk about a little bit, at the University of Utah. She uses qualitative methods, powerful observational data sets, and collaborations with translational scientists, that's a mouthful, to improve shared decision making for older adults, which is a very important topic for those with venous thromboembolism and other blood diseases. She is dedicated to advancing the care of her patients through both clinical practice and research. And you focus on the intersection of aging and hematology, exploring how we can improve outcomes for older adults with blood disorders. Really interested to hear about the work that you're doing. You have been funded by the National Institute of Health, congratulations, and the American Society of Hematology, and is also committed to teaching and mentoring the next generation of leaders in hematology. She received her undergraduate degree from Yale and her medical degree trained in both internal medicine and I believe in hematology as well, and served as chief resident and received an aging research fellowship at the University of California, San Francisco, and you are now based in Utah. So Anna is also a member of the National Blood Clot Alliance Council of Emerging Researchers in Thrombosis, and I'm sure will be on our medical and scientific advisory board in a few short years as well. We are delighted to have you back, Anna. Thank you so much for joining us tonight. I'm excited for this topic. Okay, so before we get cracking, we're going to turn it over to my PEP partner, Todd Robertson, who's going to lead us through some poll questions and results before kicking it back to us.
You know, I had to laugh at that because you're saying cracking, and I'm aging,
My
and so
bones.
every time I
Breaking my
move, I'm
bones.
making a noise. Something's creaking, cracking. You know, it's just the way it is. Okay, folks, you know how to do this. I think if you've never seen this, just answer these real quick, and then we're going to read the results. Have you or a loved one experienced a blood clot after age 50? Yes, no, not sure. Question 2, which factor do you think increases the risk of blood clots the most as we age? This is a single choice: reduced mobility, medications, other health conditions, all of these factors. Not sure. The third and final question: how confident are you in recognizing the signs and symptoms of a blood clot? Very confident, somewhat confident, not confident at all. If you could answer those, we will check out the results, and then I'll hand it back to Leslie so we can get this awesome episode. And I'm so glad you're here. Everybody loves you. Love the way you communicate. Looking forward to it. So here are the results. Let me scroll back up to the top. Have you or a loved one experienced a blood clot after age 50? Yes, 84%.
Wow.
No, 14%, 2% not sure. Which factor do you think increases the risk of blood clots the most as we age? 17% said reduced mobility, 2% said medications, 3% other health conditions, 61% did say all of these factors, 16% not sure. And the third question and result: how confident are you in recognizing the signs and symptoms of a blood clot? Very confident, 26, somewhat confident, 59%, not confident, 15%. So interesting. Leslie?
We have our work cut out for us tonight.
Mm-hmm.
Hopefully provide some great information to people. So Anna, before we get started, I know you are a faculty member of the Center of Aging at the University of Utah, which was something that was new to, I think, both Todd and I. And you recently were awarded a very prestigious award, the K76 Beeson Award, by both the NIH and the National Institute of Aging. I didn't even know there was an Institute of Aging, I'm embarrassed to say. And you have a 5-year research project titled Advancing Patient-Centered Decision-Making in Older Adults with Venous Thromboembolism. Wow. So aging in VT is clearly something that you're extremely passionate about. I'm very thankful for that, by the way, because I'm now 61. And so we want you to tell us, like, what does all of this entail? What is the Center of Aging? What do you do? Why are you focused on aging in VT? And how can this actually help our patient community? I mean, you saw that big number of folks tonight are over the age of 50 and have had a blood clot. And I'm hoping that the work that you're doing kind of um, sets a standard to include people over a certain age to be involved in research and trials, because a lot of times we're excluded from those things.
Thank you all so much for having me. I'm so excited to be here. And yeah, I just think this is a great topic and, relates to so many people, but doesn't often get sort of like the press coverage that it might. But really what led me to this is just my own clinical experiences taking care of patients. Really, truly, I can think of like one patient in particular that led me down this path. And what struck me at the time and what really still drives me is that, the problem with aging is that it's kind of a double-edged sword. Your clotting risk goes up, but your bleeding risk also goes up. So it's always extremely challenging to balance those two risks. And what I found difficult, just clinically, was figuring out how to do that. And that's the exact scenario that the geriatricians really have figured out. Because as people age, this is exactly what happens, right? They just get all these chronic conditions often, or life circumstances change. And you kind of have to have these conversations that are difficult as you're trying to weigh the risks and benefits and make trade-offs. And it's the science of geriatrics and aging science has advanced so much to really be focused on like making a decision for an individual patient that incorporates their values. And certain fields have really adopted that ethos. But what's interesting, I think, about the clotting field, and I think this is changing, hopefully, knock wood, is that, right now, if you read the guidelines, an 80-year-old with dementia who has a life expectancy of, 6 months is treated the exact same way as an 80-year-old who's like running marathons.
Mm.
And that probably doesn't make a lot of sense. It's probably not what they would want, but we just really don't know right now. We know very little about even just like the basic natural history, what treatments are the best, and it can make decision-making really fraught for people. So that's the whole premise. And I think I'm really excited to hear what people on this call think is important, because I think it's sort of a new way to think about blood clots as like not one problem, but one problem as part of a whole person, and how to integrate that into the decisions we make.
Mm. Do you think that there's a need for, clearly there is, but at least for interpretation, that there's a need to rewrite guidelines for people over a certain age?
Well, okay, I am not on the guideline committees. I'm much too junior for
But
that.
if you were,
Way above my pay grade. So the reason I bring that up is that it has really been done in other fields. So a good example would be atrial fibrillation.
Mhm.
Some of the guidelines now explicitly say that as people get older and more frail, and they have other competing issues, especially bleeding risk factors, or if their priorities change, that actually you should have a shared discussion about whether to stop versus continue blood thinners. And that's nowhere in clotting guidelines. Although if you talk to, if you go to conferences and talk to patients and talk to clinicians, it's like definitely sort of like the elephant in the room. Is that these are always the things that kind of keep us up at night, patients and clinicians and caregivers. So, I'm hopeful that that's the science that can inform the guideline writers is actually taking more of a geriatrics lens that incorporates all that stuff, to kind of mimic some of the other specialties where that's become the case.
So this sounds like something that we as an organization, with all the folks that are interested in this topic, we should be organizing ourselves to really help drive that process, because there are also many different guidelines from different organizations. And we posted about this over the weekend, is that we want patients to know about the guidelines. developed by clinicians for
Totally.
clinicians to treat patients, but really patients, the more you know, the better it is for you. And so I think there's an opportunity for us to really talk about, not just hematology, but vascular and cancer and how all of these different guidelines impact the patient community. And we should all be aware of them and how they're
Oh,
used.
I so agree with that. I mean, those guidelines are hard for me to read.
Mm,
So, I think, yeah, there's a lot of work to be done to sort of like integrate the patient perspective. And I think, the 2/3 of people who have blood clots are older. And we define older in geriatrics as like over age 65, but you know, yeah,
Yeah, I got 3 more years.
you
Woo-hoo.
guys are safe. So it's like almost everybody who has a blood clot, or the vast majority, kind of fall into this category. So I'm with you. I think it's a great idea. I think in order to update the guidelines, though, we need the science.
Yeah.
So, and I think that, there's a lot going on in this area, but it's not really, I think there's a lot more that can be done.
Great. Okay. Thank you for that. Todd?
Yeah, I mean, we're talking about the aging population, and roughly, what is it, 18% of the US population is over 65. And if you include 60 and older, we're talking about almost 30% of the population in the US. We know that aging is a risk factor for blood clots, but why is that? And how does aging increase the risk for blood clots? Can you touch on some of that?
Yeah. Oh, it's such a good question. So the other thing I'll say is that you've probably seen the sort of like panic New York Times or Economist headlines about this, that the worldwide population's aging because the fertility rate is going down. And so the projected estimates are that this is, clots are going to become even bigger public health burden because it so disproportionately affects older folks. So I think that's why, this is really kind of an urgent um, public health issue to address. So there's some thoughts about the reason that the risk of clots goes up so much. It's probably multifactorial. So certainly there's changes in biology. So there's this concept of inflammaging, where as people get older, there's just more chronic inflammation, kind of no matter what you do, although you can combat it with, healthy lifestyle is the thought, but some of it is just part of your cells getting older. And there's a lot of work, basic scientists are doing a lot of work to reverse that phenomenon, but it's a known phenomenon. And inflammation is really closely linked with clots, in that it kind of just revs up the clotting system, which I'm sure many people on this call know, because a lot of these sort of inflammatory processes like surgery or hospitalization, that's just really an inflammatory insult and can provoke a blood clot. So that same process is going on in a more chronic way as people age. So that's probably part of it. But then there's all the other stuff that happens with aging too. So people get more risk factors for clots. So people develop obesity, which is a risk factor for clots and recurrence. They get other comorbidities. So maybe things that make them less mobile. And so it's sort of all of those things combined. It's sort of like the underlying biology and then also the other risk factors. So it's sort of a hand wavy answer, but it's probably a mix of biology and then other risk factors and conditions and medications as well.
Yeah,
What?
and I mean, a lot of people are, the immobility part. I mean, they have a lot of people have a lot of health issues that don't allow them to be able to even go out and take a long walk and do this other stuff. And we get so fragile as we get older. And one thing I preach about in the group a lot is having good grip strength, good reaction time, because we fall so much easier, and it takes a while for us to react. It's just a longer process, and so a lot of people are afraid to be mobile, even and forget about being on anticoagulants, but they're kind of afraid to go out there and do that. So I know that that's a big issue with the patients.
Absolutely. I mean, I always reassure people that, our definition of immobility is like literally you're not getting out of bed for 72 hours except to use the bathroom.
Yeah.
But we know that all of this is, there's a close interplay, and like for your overall health, mobility is super important. But I'm with you. I think it's just one of the many things that plays into the increased risk.
Leslie?
Just a question, because we were talking about this earlier. So we're talking about venous thromboembolism. So we're talking about the big veins for the most
Yeah.
part, especially with DVT. How different are those veins in an older person than a younger person?
I love this question. So there's this inflammaging process that I was talking about that causes alterations in the proteins in the blood. So the pro-clotting proteins, there's an imbalance, right? But that's in the blood itself. But there's also lots of changes in the stiffness of the vessels over time. So we think about that a lot on the arterial side. That's why as you age, hypertension is much more common or high blood pressure is much more common. The same is true on the vein side, in that the composition of the veins can change over time. They become stiffer. People can get varicose veins, which are, one risk factor for clots. So, yeah, there's a lot, and then they can get venous hypertension too. So basically, like you get venous stasis, which has a lot of implications. Like one of them is probably just it alters the way the blood flows back up to the heart and can cause kind of congestion that can prompt clotting, but then also, it can make it hard to distinguish between like what's a clot and what's just, swelling. It's a
Hmm.
super common issue. Um, so yeah, it's likely both. It's like I always explain it as it's a plumbing issue. And it's like what's running through the pipes. It's all combined.
Okay. So there is some commonality with arterial in that over time those veins get beat up a little bit and makes it harder to move the blood flow around.
Yeah, your valves are a little more leaky, especially if you've had clots. It can just disrupt the anatomy of the veins. But it's not a foregone conclusion that you're going to get a clot just because of that. It's likely that that is like one of the many things that
Hmm.
leads us down this path.
And slower circulation. Todd's always harping on us to, and then in a good way, Todd, to put muscle mass on our bodies. And by doing that, if you can, does that improve circulation?
That's the hope. So, this has probably been most well studied in two scenarios. So one is post-thrombotic syndrome. You guys have, I'm sure, talked to like true post-thrombotic syndrome experts,
Yeah.
but my read on the situation is that, not much that's been tried makes a huge difference. Like individual patients can get a lot of benefit from compression stockings and things like that. But the trials, they haven't seen huge benefit from that type of intervention. But what does seem to make a difference is exercise. And that's probably multifactorial, right? But some component of that is probably like actually building muscle to squeeze the blood back up.
Hmm.
And it's just gravity, right? And then the second place where it's been studied is sort of like after you have a pulmonary embolism, is doing exercise afterward. There have been some clinical trials and there's more ongoing that have basically looked at, like doing a structured exercise program. And this is challenging because I think just like Todd was bringing up, that can be really nerve-wracking after a clot. But there's some data to show that likely that helps with both recovery from the pulmonary embolism and probably with preventing another clot and possibly with reducing your bleeding risk because it's all tightly linked, right? Balance and falls and bleeding and even just like your overall health are all closely linked. They're all tied together.
Yeah. So to take out of his question, we've got the physiology, aging and physiology. We've got blood vessels that stiffen and valves that weaken. We potentially have slower circulation due to not having enough muscle mass on our bodies. I got to get back into the gym to lift some weights. And comorbidities, i.e. medical conditions. What about surgery, hospital
Mm.
stays, et cetera?
Yeah, this is the other, so it's kind of like a chicken or the egg, right? So you've got more medical issues in general. And then some of those medical issues might lead you to having what we call provoking events, like being in the hospital or getting a surgery. A new cancer diagnosis is more common as people age. Certain medications like testosterone or sometimes estrogen, or, there's just, the
Yeah.
list goes on and on. So it's like, this is why you need to apply sort of a different lens to older folks because they often have a million things going on at once. It's really rare that a blood clot is like the only thing that's going on. It definitely happens, but it's pretty rare. It's usually like multiple dominoes aligned perfectly, and then you knocked one over and then the rest come tumbling down. And that includes surgeries, procedures, just all the biology, all the other comorbidities. You're exactly right. It's never simple.
Okay. So, Todd had thrown out some statistics. I'm gonna throw my own statistics out here, Todd, because we're having dueling statistics today. So it's estimated that about 2/3 of all VTE cases occur in people over 70. And more than diagnosed DVT cases in hospitals are in people over 65, with comparable numbers for PE, which surprised me. Is there any difference in the incidence rate, including mortality, related to men versus women as we get older? I had read recently that between the ages of 65 and 79, men actually have a higher rate of VTE, but when you get to 80, that it basically evens out between the two. And then the second part of that question, if you forget, I'll re-ask it. But what are the most common types of blood clots in older adults, DVT or PE? Or you can work backwards if you want to.
Okay,
Is there a
sounds
difference
good.
between men and women? Like, I know women have unique risks associated, to their lives or throughout their lives, and then they get to the 65 number, and it seems like men then go higher, and then we all kind of plateau out together. So Todd and I, you and I have something to look forward to when we hit 80, I guess.
We're gonna make it too.
Okay, I'll answer the first one, or the second part of the question first, because that is fairly straightforward. So it's interesting. It does seem like older people tend to have pulmonary embolism more often than they have deep vein thrombosis.
Why?
Why? It's so hard to parse that out. It could be part of the biology. It could also be, though, that it's like I was mentioning, like there's so many other things going on that there may be delays in diagnosis. And there's a really interesting paper that came out a few years ago that looked at older people who presented with shortness of breath, I think, to the emergency room. And they were much less likely to be diagnosed with pulmonary embolism than younger people. There was like a delay in diagnosis, especially if they had some kind of cognitive impairment. So like, as people age, sometimes they're not able to report the symptoms. It's that they also have heart failure or they're at risk of pneumonia. And so it's so hard to suss these things out, but it seems like a fact that people have pulmonary embolism more, which, as you know, means that, they're at greater risk of death and disability from the clot itself. But why exactly that happens, I don't think we know. Is it just a delay in diagnosis, or is it something different about the biology? I think it's what's going to be really difficult to say. Some of our work hopefully will clarify that to an extent. Okay, and then the men versus women question is so interesting. I actually hadn't seen that sort of like split that you talked about. And so I was looking into it. My take on some of the papers I read, I hope you send me the one that you read, Leslie, because
Okay.
maybe I am not looking at the same thing. Overall, men have higher risk of VTE, but you're right that like women, there's certain times of life where the risk is high, and then men also have higher recurrence rates. So it's something that we factor into our decision making. But the split as people age is really challenging to sort out from like an epidemiologic standpoint, because also as you get up into those upper age echelons, women live longer. And so it's possible that the rate evens out because more men have passed away, unfortunately, and the women are living long enough to get their VTAs. So all that is to say that we know for sure that regardless of whether you're a man or a woman, your risk of having a clot goes up as you age. The oldest old also tend to be healthier. That's the other kind of interesting thing. And that like if you live to 90, then typically like you're a healthy person, not always, but and so you see it changes the type of people who get clots as they get older too. So it's a tough thing to sort out, but the general statistics are probably what I would keep in mind most. The other thing is that we can't really modify that. You know what I mean? That's not something you know, you can't change if you're a man or a woman. You can only change the things you can change. And you also can't change if you're getting older. So these are just some obviously with their medical exceptions to that, but when we think about these risk factors, I like to think about like could we do to sort of prevent the clot or prevent the side effects from the treatment of the clot as people age.
So you're saying that men have a higher reoccurrence rate.
They
I mean,
do.
I've had 7 blood clots. I may have an eighth, who knows? But I kind of know most of those clots. I know the reason behind it.
Mhm.
But we also, as men, you know, talking to the guys here, we also increase our risk for blood clots as we get older. So I mean, we get really, you know, good at abnormal clotting. Why is that? Why do men have a higher reoccurrence rate?
Again, I'm not sure we fully understand why, but there's probably lots of factors that play into it that we do know about. Probably some of it is just the accumulation of other things, like other comorbidities and all the other things that we've been talking about. But there may also be other biological differences that are driving it that have to do with the rate of accelerated inflammation and aging that goes on. It's probably a bunch of different things, but
Yeah,
it's just something we see when we look at big data. It comes out in basically every study.
Hmm.
But then the other problem, right? We're talking so much about clotting, but really the other thing is that the bleeding risk goes up a lot too.
sure.
And it goes up with age, kind of tracks perfectly. So that's why you sort of end up in these catch-22 scenarios.
So you're saying get all the mountain biking you can in now before before I hit 70 because you know I've been known to wipe out a few times, but
I
I
want
guess,
you to
hey,
know
I'm
the
staying
man.
active. I'm staying
Yeah,
active. You can't
it's
say
so
I'm not
good.
staying active.
I think I'm in agreement with that.
so I guess when you turn 70, I'll come get your bike and I'll get on and start riding your bike around.
You're not gonna get all my bikes, but you can have one of my bikes.
Love it.
Todd, you're up next. And actually, there's an interesting question from Michelle in the chat that kind of ties in a little bit to the next
Go ahead.
question that you have. No, you go.
It's in Q&A.
Yeah, about improving access to genetic testing and other info about what may have caused our clots. Does that info help the decision-making process around VTE prevention as we age? And it ties into your next question a little bit that you were going to pose for Anna.
Okay. Well, and I wanted to ask, going back to some of the personal health factors, like the genetics, we were talking about the
Yeah.
medications, the chronic conditions, the natural rise in clotting proteins, those raise an individual's clot risk as they age. Are there certain medications? Are there certain genetic factors that we know about? Like in the medication, are there certain medications that might raise that risk over other medications? And then I have a follow-up question, but if you can answer
Okay.
that one first.
Yeah, it's a good question, a complex question. So, um, I know you guys have had talks about thrombophilia in the past and inherited thrombophilia in particular. So like genetic disorders that people inherit that increase clotting risk. I would say that in general, those probably become a little less important in terms of the underlying driver of clots as people age. Meaning that if you have your first blood clot when you're in your 60s or 70s or 80s, your hematologist or whoever you see is probably a little less likely to be thinking about those disorders because especially the stronger ones tend to present earlier. Not always, but they do tend to present earlier, and then you tend to have a really strong family history um, and of early clots or abnormal location clots. And as people age, those sort of inherited things, this is true in all diseases, those sort of inherited things become, if you look at, they just become less important in terms of like what number of clots they explain.
Mhm.
And the larger group of patients has other stuff, just like all the other things that we've talked about that play a greater role. Now, there's definitely exceptions to that. Of course, there's patients who have these really strong clotting disorders or acquired things like cancer or a myeloproliferative neoplasm, like a JAK2 mutation, which maybe some people here have. Those things do start to go up, or antiphospholipid syndrome, for example. Those things do start to become more prevalent as people age, but those are not inherited, those are acquired.
Sure.
I got a little lost. What did I miss in the question?
Well, no, that's fine. I wanted to ask you kind of a follow-up
Okay.
though, is, we talked a little bit about the preventive measures.
Yes.
What other kind of preventive measures can we, because I'm thinking trying to keep a healthy weight,
Yes.
definitely staying hydrated, things like that. I mean, a lot of the things that the younger crowd, right, would be, but what kind of preventive measures do you think we should focus on? That's the first question.
Yep.
The second follow-up question is about compression, because we know that compression can help manage PTS and prevent PTS. I see myself struggling putting on compression sometimes, and I'm only 61. Yeah, when we're older, that seems like a really difficult thing to
Yes.
do,
Mhm.
for the elderly to be able to do that, especially if they're not very mobile. What do they do in those situations?
We're strong. Yeah.
Mhm. I love it. So, these are such great questions, and I actually totally agree with you. Probably the biggest thing that people can um take action on is maintaining a healthy weight. Because we know that obesity is a risk factor for clots. Um, we and also like keeping in mind that's probably the best thing for your overall health is maintaining a healthy weight.
Yeah.
Whether sort of like these new weight loss medications or surgeries and things like that are actually good at preventing clot or preventing recurrent clot, we don't know yet, but we do know that maintaining a healthy weight is probably the biggest thing you can do. Um, and then in terms of the other stuff you mentioned, I think none of it is harmful. We can't say with certainty if it's helpful. Um, if that, I know that's sort of a cop-out answer, but we know it's great for your overall health. So, and things that are great for your overall health are important not only for the clot, but also your ability to tolerate the treatments for the clot, is a big thing, right? Because as I was saying, bleeding is another thing that I always worry about. And if you're frail, falls, you have heart disease, so also need to be on aspirin, all of these other things, they just make the situation a lot more complex. And so maintaining a healthy lifestyle and doing things like being active is super important. Compression stockings is tough. The science is not settled on compression stockings, to say the least, but I do have lots of patients who are helped by them. But I also have lots of patients who say exactly what you say, which is like, I almost got divorced because my wife had to help me with my compression stockings,
Right.
which I don't want to advocate that. There are some sock, what are they called? There's like adaptive equipment you can get at a medical
Yeah.
supply store that helps.
Like in the hospital?
Yeah,
Yeah.
exactly. That helps you pull up your socks. And I've sent many patients
Oh,
to get set up with those. Oh yeah, they're sort of like a sock hook, basically, that helps you pull up your sock. And if it's a compression stocking, like helps pull up that super tight compression stocking. Um,
mhm.
and, but I also, a big thing that I do is, a lot of this is like what it's all about your comfort and what you can tolerate and what your goals are. So for some
Right,
people, it's like, it's not worth it. And so why are they
right.
torturing themselves? Whereas for others, it's like no big deal. So that's where having a conversation about your goals is, I think, the most important thing. And then trying those small strategies, like I was talking about, like just get one of those sock hooks and try that.
Yeah,
Or don't do thigh highs, do knee highs if that's more comfortable. Or
right.
wear them for part of the day if it's too hot. All of that stuff I think is totally kosher.
Yeah, and I want to make it clear that when I'm talking about backing up, going to the gym and building muscle, I'm not talking about trying to look like the Hulk. I'm not talking about trying to bench press more than you've never. I'm talking about building lean muscle.
Mm-hmm.
Now, when I had my shoulder surgery, I've lost all that lean muscle. I've got to gain that back. So just real quickly, I don't want Leslie, don't get mad at me. I'm not trying to get too far off track, but we were talking about weight loss. I was always told that building lean muscle and having lean muscle can help with weight loss. Is that true? And can I ask why?
That's a great question. Um, I probably am not the best person to answer that question, but
I threw it at you.
I would believe it. I would believe it. I think the science behind weight loss is getting really complex and
Yeah.
probably beyond um what I can weigh in on. But I do know for sure when it comes to things like post-thrombotic syndrome, having lean muscle mass to basically like compress the veins and help push the blood back to the heart is, I think, very likely to be borne out as one of the most effective strategies. And can be helpful for recovering from a pulmonary embolism, and then is also very helpful for just keeping basically your ability to survive insults. Like if you were to have another clot or you were to have a
Mhm.
big bleed or whatever else life
Mhm.
throws at you, that's probably the most important part of
Yeah, people really struggle with that. Medical conditions, being immobile because of those medical conditions, physical ailments. It's really hard for them to lose that extra weight. So I think we need to keep encouraging them. I think too many of them get shamed at the doctor. I think they get shamed by other patients, by other people, and I don't think it's right. I think there's a constructive way to say, look, if we can reduce the weight, we can kind of reduce the risk and make you feel overall better, help you
Yeah,
through
so
recovery. But it's
we have several recorded PEPs on that topic. I encourage people to go to our PEP library. Can we just circle back to the medication comment that
Yep.
Todd had touched on before? Because as you get older, typically you are on different medications. And so is there anything that really jumps off the page in terms of what people should be aware of that could increase? I mean, you talked about testosterone, but I don't think that's a medication per se. Uh, Anything that jumps off the page, like we have a comment from one of our folks tonight, who was on, I think she was on something for osteoporosis. I'm trying to find her comment, but she was taking a drug for osteoporosis and she ended up getting a blood clot, and she also had, I think, bunion surgery as well, she said. Any medications that you can share with us that can cause an inflammatory state, making you more prone to blood clotting?
Such good questions. So
Thank
the
you. It was raloxifene.
raloxifene, interesting. Okay. Yeah. So there are so many medications that can potentially increase your clotting risk, and many of them are used like quite commonly. So yeah, there's the hormonal type therapies, um, like estrogen and testosterone. Steroids are known. Chemotherapy, many of the targeted agents for oncological conditions. People are living longer and even getting cured, that those can cause clot. Raloxifene, I actually have not seen. I'd have to look it up, but I wouldn't be surprised.
what about antidepressants? Because a lot of people in the groups suffering emotionally, they want to be put on an antidepressant, but then they hear there's a clot risk with it.
That's not a strong risk factor for clots, and I would have
Okay.
no hesitation putting people on an antidepressant. SSRI is a specific type of antidepressant, can sometimes increase bleeding risk. And then the key thing, and maybe this is part of the discussion that they're having, is that a lot of medications can interact with the direct oral anticoagulants.
Mhm.
And so sometimes people do worry about these interactions between the drugs, but that's something a pharmacist can take 3 seconds to look into.
Right.
It should never be no, there's no harm. There's definitely no contraindication in starting antidepressants.
Okay.
So there's a whole host of medications that can kind of contribute to the increased risk of clots. But many of them, it's not the sole risk factor. Oftentimes there's like something else going on at the same time. And oftentimes it's a tough balance, right? To be totally frank, I worry more about the other medications and bleeding risk. I know I keep coming back to that, but I can't tell you, there's like an epidemic of aspirin being left on when people start a blood thinner, which is so dangerous. It hugely increases the risk of bleeding and oftentimes is completely unnecessary. So I would just strongly encourage people to talk very seriously with all of your providers about aspirin if you're also taking a blood thinner. You oftentimes do not need both. Some people do. And in that case, there's risk mitigation measures we can take, like being on a proton pump inhibitor. And then the other things I worry about are things like ibuprofen, Advil, which people are using, right, for their aches and pains. And I mean, I use them too. They're really commonly used, but those things interact with blood thinners, as I'm sure many people on this call know, and can greatly increase your bleeding risk.
I do take a leave, but it's guided by my hematologist and my orthopedic surgeon.
Yep.
So it's not like you pop them every day. You,
Yes.
you know what I mean? There's a certain day that you do it, certain day that you don't,
Totally.
and that works fine. But people shouldn't go around just popping them like M&Ms.
I think that's where you run into trouble, is just like the
Yeah.
daily chronic use. But if you're having a frank conversation with people, then I think there's a time and a place,
Yeah.
but it needs to be a discussion. So
Yeah, for sure. I think this is actually really interesting in something that we should do for our community is get with our pharmacy friends
Yes.
and put together a list of things that we know older people take, well, people just in general, but older people in particular, and provide that to them to, say, hey, if you're taking this, you should be aware that it could impact clotting risk so that they have that available to them. Because this is, I think about what I take and I'm like, gosh, I need to go back and check and make sure that, I'm safe.
Yes, totally. I think, you know, pharmacists are like, especially in the anticoagulation world, these are quite dangerous medications. They're
Yeah.
the number one reason for older adults to be seen in the emergency room, blood thinners. And so, both looking into medications that increase your clotting risk and also talking to a pharmacist about potential interactions between your blood thinner and other medicines, especially before you start a new one, I think is probably the most important thing you can do to keep yourself safe.
Okay, so let's move on. We do want to talk about long-term health and outcomes. So, are there long-term effects of having a clot in older age? If you get a clot, you're over 60, 65, 70. Are there long-term effects for that are different from younger folks? And does surviving a clot at that age increase the risk of future events even more so than if you're younger? And then should we be screened more often? I was at an awareness event a couple months ago, and there was a person who does ultrasound, and she looked at my ankle and she said, "Oh, your left ankle is swollen. I should ultrasound you." And I was like, "Oh my God, like, should I be doing this on a regular basis? Like, should we be getting, different tests done on a more regular basis? Should we just be asking for these things?"
These are such insightful questions. So, in terms of long-term effects, so what we know is that um, having a clot can have lots of effects on your quality of life, and they seem to be more impactful as people get older. And that's likely for a lot of reasons. Many people, they just have less sort of like resilience. They have less ability to respond as they get older and bounce back. It's the same way that's like harder for me to go to the gym now than it was when I was 20. It's the same phenomenon. Um, and The other thing is that, many people after they retire are on a fixed income. So that's something that I think, in my own work, talking to patients with blood clots, I think is not like brought up enough or talked about. It's, people are not given an option that is central in that option is
Good point.
cost.
Yeah.
And it's a huge issue for people is the financial burden. Um, uh, I think all of those are really important as people get older. And like I said, because people tend to have pulmonary embolism, there probably is, like more, if you look at like all comers, there's probably more health burden as people get older when they have blood clots, probably in part because they have more pulmonary emboli, which just tend to cause more disability. That's what we're really talking about here is just disability. The other question you asked is that um, it's not, it is true that as people age, their risk of having another blood clot does go up. And so as people age, the clotting risk rises, like for your first clot, but also for having a second blood clot. But it does seem like, the anticoagulants are very effective. And we'll come back to that. We can talk a little bit about dosing and stuff like that. But the screening thing is that it's a really interesting question. Um, I think that would have to be studied, basically. What I would say, like I was mentioning before, is that what I think is hard as people get older and just have more things going on, is that it can be really challenging to sort out, like, is that ankle swelling because I just took a flight and my ankles always swell when I
Yeah.
fly? Or is it a new clot? And I guess people age, it just gets, is this because I have heart failure and I am having fluid overload? Is my shortness of breath from, COPD or some other chronic pulmonary condition that gets more likely as people get older? I would say what's important is to advocate for yourself, as you guys all already do because you're here at an NBCA pep talk. But I think it's easy for clinicians to get distracted when people have a million medical problems. It may not always be the thing that people are thinking about. And so I think that's probably the most important thing is it can be hard to separate the wheat from the chaff as people get more complex. And it's often not the only thing going on. And so that applies to both the clot and also your decision to get treated. It's
Mhm.
often not, oh, this is my only medical problem. And if I take a blood thinner, then like I'll go back to normal. That's the much less likely to be the case as people get older. And so it takes a really careful discussion about your long-term goals to decide what the right thing to do is.
Okay. I know we're going to talk about anticoagulation. Todd's going to lead that discussion, but quick question for you. The trials that were originally done on the DOACs, the direct oral anticoagulant, did they have an age cutoff, or were people above a certain age included in those trials?
This is such a good question. So you said this in your preamble, so I didn't repeat it. But like much of the evidence that we use in day-to-day practice and is in all the guidelines, would exclude like everyday people, especially older people. It depends on which drug. Some of them had an age cutoff, but most importantly, like they all basically required you to be super healthy and fit. And so there have been studies that have looked at this, and it's like a quarter of, I think a quarter of older adults would be ineligible for those trials. Um, so there's a lot of people where applying the results of those trials is probably not the right thing. Just like I said, like a 75-year-old running marathons is not the same thing as a 75-year-old who's bedbound with dementia. And we just don't know because that bedbound patient with dementia was not in those trials.
Right.
They may get benefit, but they also may have a lot of harm. But right now, if you read the guidelines, they base it on the trial, which is the best quality evidence that we have, but that doesn't really take into account the whole picture.
And if somebody here wants to read about the trial, which trial is it?
For like which
The DOACs.
the DOAC trial. So you know, the I think the one that's probably most relevant right now is the Renovate trial, which is about basically, do we do full dose forever or do we do half dose?
Mhm.
That's probably the trial that's like most relevant for a lot of the people on this call. And that's an interesting trial to talk about because it basically showed that both the full dose of blood thinner and the half dose of blood thinner are really good at preventing blood clots. They couldn't prove that they were identical, but they were both really, really good at preventing blood clots. But the half dose was way better in terms of bleeding. So that's why I think most people are moving in the direction of half dose for everyone. That's the first time that's really been shown. I think that's probably the highest yield for people.
So that's really important for people to know. And that's something that they should definitely be discussing with their clinician if they're not aware of it already. And this is why we want people to know about the trials. We want them to know about the guidelines because it influences your protocol and how
Yeah.
you can be treated and possibly reduce your risk of bleeding while maintaining protection from getting a blood clot.
Yep. Yep. There's a couple of, and if you want, I can send you a couple papers after this, Leslie. There's a couple papers that are not a trial, but what they are is like a subsequent analysis of the trial data that actually looks at age, also looks at frailty, which is sort of like a marker of sort of like as people get
Yeah.
more disabled as they get older, and compares different DOACs. And those, it's again, that's like more taking that trial data and like reanalyzing it and putting these aging risk factors in there. And those studies pretty consistently with really strong statistical methods show that Eliquis is likely the safest,
Mhm.
especially in older adults. And that's because it has the lowest bleeding risk and is very, at least as effective and in some studies more effective than other options at preventing recurrence.
And it's the Renove trial, RENO.
Renove trial is the reduced dosing trial.
Okay.
And then I don't remember the name of this paper off the top of my head, but I'll try to Google it while we're talking to put it in the chat. How about that?
Okay. Okay, great. Because I know some people are interested, and then share it with us, and then Todd will put it out into the group.
Perfect. Perfect.
Yeah, and I agree about Eliquis. I've been on Eliquis for a year now after, 13, 14 years on Xarelto. And Eliquis has controlled my aggressive clotting disorder real well and really well. And because I am active and do mountain biking and stuff, I feel a little bit more confident on it because of some of those studies, but I think Eliquis is a good DOAC. And I do want to say real quick that, and maybe not everybody's going to agree, but I've learned to give my doctors a little bit of grace because we were talking about how busy they are. I mean, they've got a cattle call line of patients every single day. And it's like, I think it's really important that we are our own advocate and make sure we have these conversations. And if we can't do it, maybe I wish I could go around with patients and just talk to them and their doctors, you know, because they kind of need like a middleman sometimes. But, you know, I try to give them some grace and I know they're doing it. And I think you're doing a great job. I think all my doctors do a great job. I couldn't do that job. I don't know how they do it. But let's back up to anticoagulation just real quick. I know we touched on it a little bit. I just want you to go over again. What are the risks of anticoagulants in older adults? And more importantly, you know, how do we mitigate them? So I'm talking intracranial bleeding, brain bleed, GI bleeds, falls and trauma, kidney or liver dysfunction, dosing errors, monitoring challenges. I mean, I know what I do to try to be more stable and not fall. I mean, I've got my squeeze ball right here and I'm trying to improve my grip. So when I need it, it's there. You know, there's like muscle memory things, but how do we mitigate some of this stuff?
Yeah. So I saw it in the chat. A couple of people bring up that like even just the bruising bothers you. And I've heard that so much. And like it affects like what you feel comfortable wearing. It affects whether you feel comfortable playing with your grandkids because you're worried. It just is a really big deal. And so I completely agree with you. So big picture, there are lots of things that affect bleeding risk. And we don't have a perfect way of predicting bleeding right now, but there's several risk factors that come out time and again. So age is one of them, which we already talked about. That we really can't change. Kidney dysfunction is another one. If you've had a big bleed before, that's a really good sign that you're at risk of having another one. Cancer is another condition that definitely increases your risk of bleeding. I already mentioned the things that really worry me, which is things like being on aspirin at the same time or other drugs that can cause blood thinning. That's probably the biggest thing. Falls is tricky. We, you know, it's possible that falls is something I always do think about falls because if people have a lot of falling, then it increases their risk of not necessarily the bleeding itself. That actually is not completely clear, but definitely the downstream consequences of bleeding. Falling does make me worry about it because they can have more trauma or they can bonk their head. So those are all things. And so there are things you can do to mitigate those issues like we talked about before. I think the biggest thing is the aspirin and using those other medications, and then just thinking about all those other conditions. It's a really difficult, this is why it's such a hard thing. And that's why, you know, really, honestly, truly, sometimes those risks are quite balanced. And many of the people on this call, I'm sure, are taking blood thinners, but it's, I think, worth a discussion about the risks and the benefits if you're having a lot of bleeding problems.
Absolutely.
Because bleeding is really dangerous. It actually can cause more harm. Often it has more risk of death than recurrent clot. We don't think about that. It also has more risk of disability, which is some of the work that I've done with my colleagues, which is something that people tend to care about a lot, like ability to live on your own independently, and do the things that you like to do. Sometimes that's more important to people even than like how long they live.
Sure.
But you don't know if you don't ask. So that's where I think it needs to be reframed a little bit, in my view. And I think a growing population of people that we kind of have a discussion about the risks and benefits and that it needs to be reassessed as people's circumstances change.
Absolutely. Yeah. Okay. Thank you. Leslie?
The Einstein trial, that's what I was trying to think of.
Yeah, sorry. I think I misunderstood what you were asking me. So there's Einstein, Amplify are like the big DOAC trials. So if people want to read the original trials from like the 2010s, those
Yeah.
are the big DOAC trials. The more recent ones I think are worth talking about. There are, and you should not hesitate to bring them up, are Renove, RENOVE.
Yep.
And then I'll send some of the claims studies, which are basically looking at people actually on these drugs.
Yeah. And we'll put all of these on our site so that people can easily access this information. So, another question for you. I know we don't normally talk about, we talk about different subspecialties and who's involved in treating the patient.
Yeah.
But one of the things that we don't talk about is the role of the podiatrist. And this actually came up in a conversation with a couple of clinicians last week, about how important the role of the podiatrist is when you get older, or if you have an older parent or you're taking care of somebody, because they're oftentimes more likely to see an older patient than a PCP. And so they'll be aware of chronic conditions, diabetes or peripheral vascular or foot changes or thicker nails or whatever it may be. So how do you incorporate, like, as you're doing your work on aging, how do you incorporate them into the overall treatment protocol, if you will, or the team of an aging person? Um, and so for those of us that are caregivers for older people, how do you incorporate them into the role of VTE prevention care?
I love this point. I mean, I think the key for an older person is that it's not a doctor-led team. It is really like it's a village. And so because often, like you said, it's actually like the home health aide who knows what's actually going on
Yeah.
with the medications or whatever it is. And so podiatry is like a perfect example. It's not something that like I definitely didn't learn like any podiatry in medical school or, anything. But it's so important. Specifically about podiatry, I think the things just from my clinical experience that I've seen, definitely, as you say, like they may be some of the first people to pick up on symptoms. Um, Secondly, like, it's sort of like an underreported symptom or side effect of blood thinners, but they can affect wound healing. So, I have seen that be an issue too, that podiatry often picks up on. The third thing though that I think is also important is that podiatry does a lot of procedures and surgeries and they immobilize people sometimes. And for people that have blood clots, it's just always really delicate. So having that clear communication is so key. And I think but the larger point is, I think the most important, which is that the physical therapist, the home health aide, the pharmacist, the social worker, um, and the doctor and all the different specialists, especially like a geriatrician or a PCP, it's all becomes increasingly important as people age. It's not just a one-man show or woman,
Right.
one person
Yep.
show anymore.
For sure. So that's also an area we're going to spend some more time because it is important, particularly as we're talking about an aging population. The bill that got signed into law in Florida, the Emily Atkins bill, when we started to work on this, I think it's more than 25% of the population of Florida is over the age of 65. So, your point about people are aging, we have an aging population, is certainly very, very true. Okay, so I know this has been a great conversation. Thank you so very much. I have so many more questions, but I know we have a time constraint here. So I'd like to see if we can maybe move to some of the questions for a little bit.
Great.
And Todd, do you want to kick it off or?
Yeah, sure. And actually a little show and tell, but this popped up in the Q&A box, and I think it's important for all ages. And I'm wondering what you think about for the older population, because that's what we're talking about. But do you think it's important for someone with a past DVT and multiple PE history to have a medical alert bracelet to say they are on a blood thinner? So I wear road ID. I wear this everywhere I go, especially when I'm active. But as we get older, it seems like that wouldn't be a bad idea to have that on that would name the DOAC, the anticoagulant that you're on, maybe even a little bit of history. Do you think that they serve a good purpose and they're important?
It's always part of my spiel.
Nice.
Uh, but I always couch it with like, you have to figure out what's going to work for you. So for some people, they don't want to wear a bracelet or a necklace.
Right.
But on your phone, you can fill out your medical history, and paramedics do look at that. It's really if you're not able to speak for yourself. So I think there's relatively little harm, and there's a way to do it that's discreet if you don't feel like broadcasting to the world your whole medical history. The other thing, just to bring this up, I talked to my patients about, because I know we have patients from all over, is people who are taking blood thinners, I always encourage them, especially if they live in a rural area, to find out if their local emergency room or hospital carries reversal agents for the blood thinners because they're not universally carried. But knowing that, you can kind of know like what your situation is if you did end up in a really dangerous situation. We've tried in like select circumstances here with like getting people a prescription to have with them. It's like not feasible from an, cost perspective, but it's something to talk about with your hospital, your local hospital and emergency room if you
Yeah,
live.
and DEXA isn't everywhere.
Yeah,
That
I mean,
reversal
to be
it's
fair,
expensive.
we take care
Yes,
of a
it
lot of
is.
rural patients in this area, and like most even rural ERs and hospitals have it, but not
Oh,
all.
But
So
not
good
all.
to know.
it's worth asking.
Yeah. Okay.
That's good to know. So we actually have some really great questions in the chat here tonight also. Does PTS progressively get worse as you age, or does it peak and then stay the same? Anything you can do to help it besides exercise or compression?
That's such a good question.
Mm.
I mean, I think the symptoms tend to be worse in the like, not acute period, but the sort of like short term after the clot. And then oftentimes will either get better or sort of stabilize and stay stable. I'm not sure that age is like the biggest determinant of that. Um, it's sort of just the natural history of PTS itself. But for all the reasons that we talked about, age can exacerbate the symptoms.
Mhm.
Uh, so from what I have read, and to be honest, I haven't read the most recent updates of the literature, but my impression in looking at the guidelines and looking at the literature is like what we talked about is really what is backed by science is exercise and compression for certain patients. Um, there's been studies looking at other interventions like statins and things like that. To my knowledge, there hasn't been anything that has shown a true benefit, but every patient is different. So I really do encourage you to try different things and see what works for you and work with your doctor to figure out what works for you. In some cases, actually the blood thinner itself is, the most effective treatment. And in some people that's really the key.
Okay. Todd?
And someone was asking about they thought that they should see a certain they're older and they thought that they should see a certain specialist, but the doctor did not want to refer them to that specialist because they said that you really don't need it. You really don't need to see that person. But if that patient wants to see that specialist, should they go get a second opinion? Can they go out and maybe find one on their own? Does it depend on insurance? But I see a lot of our older patients run into that. They're just kind of, gaslit just or pushed to the
Yeah,
side and said, no,
totally.
you don't need to see vascular. No, you don't need to see cardio. And I think that's not a good thing. I think people have a right to get those opinions.
I think the key is that you should be able to make an informed decision that is in keeping with your values. So you should be able to get whatever information you need to make an informed decision. I think there are times where doctors see the downsides of like really invasive, intensive care, like some of these advanced procedures and stuff. And that sometimes if you go down that road, it's like a train you can't get off of. So I
Right.
do think sometimes it comes from the right place, but on the other hand, like it always has to be a shared discussion. And I also see the flip side, which is like we shouldn't say like, hey, just because you're this age or whatever, you can't get those things. Because for
Right.
some people, that's their goal. They will do
Yeah.
anything to try and feel better.
Yeah.
That's totally a type of person. And you can't be sort of like paternalistic and not allow that person to kind of like live the life they want to live. That's, I think, the key piece that's missing. Each person's different. Some people, as they get older, they want more. Some people, as they get older, they want less. But if you don't talk to them and find out what they want, you'll never know.
Right.
Yeah.
Yeah. Good point.
Absolutely. So communicate with your clinician. Okay. If varicose veins are a risk factor, but someone has already had a DVT or PE, should that person have the varicose veins treated? What is the best treatment?
I love that question. So we don't know, we don't have the studies to say that getting them ablated or stripped, whatever, has benefit. We don't know that because, and then the other important thing is, right, those procedures can have risks, right? Because it's like a
Yep.
invasive procedure and it's always complicated to manage anticoagulation around it. We don't routinely recommend that. There are certain people where it's like very symptomatic, or they have recurrent clot and it's just in that one location where we do sometimes consider it. but we tend, most of us, it's not like evidence-based to just do a procedure on everyone. So I think it has to be a very thoughtful discussion.
Okay, fair enough. My friend?
One question that came in during the registration process from a patient was, how important is hydration while taking long-term blood thinners, and how does hydration help with blood clot prevention?
I love it. So yeah, I think there's two questions, right? One is like
Mhm.
dehydration or risk factor for clots. Possibly, we think that's partly maybe related to the travel. Like when people have long travel and they get clots, it may be actually partly from dehydration. On a day-to-day basis, we don't know if it's like just, your regular old dehydration where you're out and about and maybe just don't drink enough water. It's harder to say that that's like the sole driver. The same thing goes for anticoagulation and blood thinners. It's not wrong to stay hydrated. Probably the biggest thing is to not get so dehydrated that your kidneys get dysfunctional, because
Yep.
kidney dysfunction can really increase your bleeding risk. So I guess I would say you don't have to be like a general and drink every 3 seconds.
Right.
I think it's just common sense, right? It's just common sense with the hydration.
Well, I think I saw a statistic like 60 or 70% of Americans are chronically
Yeah.
dehydrated, and chronically dehydrated does not sound good to me. That sounds
Well,
like a health issue.
and in particular for older people,
Mhm.
Yeah, yeah,
dehydration is a major
yeah,
issue.
yeah.
Okay, so let's we're past the witching hour here, so I want to be just mindful of your time, Anna. So I'm going to take a question, and then Todd, how about you take the last question, and then we
Okay.
move to our um poll questions. I think I have more questions now than before we started this, because
Oh
this is,
no, I'm
no, it's in a good way. It's such an
Always.
interesting topic, and really we need to be non-complacent about you're on a DOAC, your health, et cetera. Like we really need to just make sure that we stay on top of things. This is a very tricky question here, and I know
Yeah.
this is, we're not giving medical advice, but this is a very tricky question. I was intrigued by this. I am on anticoagulants now for life due to my strokes, PEs, and AFib RVR. I am in the process of scheduling my ablations for AFib RVR at a university hospital. I will need a T and CT scan first. Any insights for these procedures and conditions in the light of my clotting history? No known clotting disorder, still high concern for lupus and continued monitoring by my rheumatologist, and aging. So, any insights for these procedures and conditions in the light of my clotting history and aging?
Mhm.
I know that this is a question with a broad range of potential discussion. I'm not sure if it'll even be considered, but I thought I would try. It is a bit overwhelming, and my goodness, yes, it is.
I totally hear you. I always say this to people, but a clot diagnosis is like on par with a new cancer diagnosis in terms of the stress that it causes. I know I'm preaching to the choir here, but I don't think we really think about it that way. But like, if you look at the amount of emotional distress it causes, it's the same. And the other thing I'll say is that, it feels like you're alone, but I can't tell you how many patients I have who are in the exact same situation as you are. They've got clots in the arteries, they've got clots in the veins, they have all these things going on. They have to get all these procedures, but they're worried about procedures because doesn't that cause clots? It's you're not alone. It's really common. So in terms of the procedures themselves, most procedures from the cardiology doctors are actually done on blood thinner without stopping blood thinner. So you should always talk to your doctors about it, but most of them are safe to do on blood thinner. So that's one thing, is that it's unlikely that you're going to have a very long hold. If you have a hold, it's going to be very short and can be done safely in many circumstances. Again, talk to your doctor about the specifics of your case, but I think it's commonly thought that you have to hold for all these different procedures, but oftentimes they'll continue them.
Mhm.
And then just so I think your question is more like, why is this happening to me? And what do I do? So, I think taking a step back, and this is where having a primary care doctor or a geriatrician on your side is helpful, because they can help you take a step back and think about like, hey, what's important to me? What do I want the rest of my life to look like? Because for some people, having to worry about taking a pill every day is like a death sentence. And for other people, like they're so terrified of having a stroke from their AFib that that's the most important thing.
Mhm.
Sitting down and thinking about those things is really important. Um, And then a lot of the risk factors for clots in the veins overlap with clots in the arteries. So we think about them a little differently. We treat them differently oftentimes, but the risk factors overlap. So it's not, it's really common actually to run into this scenario where you need to have, people are telling you that you're on a blood thinner for multiple reasons, and they're trying to address those different reasons with different procedures. And it's common. So it doesn't mean that you're this isolated case that no one's going to know what to do with. That's not the case. It's very common. And so I think working with your doctors like you are to figure out next steps is the best thing to do, but making sure you have somebody who's on your side and helping think big picture. Not
Yeah,
just like the tiny little details of the procedure, but like, hey,
Right.
what do I want? What matters to me?
yeah. No, I think that was a really interesting question. She's going to have all
Totally.
these tests done, and what is the implication of age on having these tests done? So thank you for that. I know we have a lot more questions. We're not going to be able to get to everybody tonight. So Todd, I'm going to ask you to select the last one. But before you get going, I know we talked a lot about anticoagulation, the risks associated with bleeding. I just want everybody who's here tonight to know that there are trials ongoing for new anticoagulants, the factor 11A, 1111A, that have shown some promise in trial. It's not 100% yet, but they're showing some promise that could come to the marketplace and have significantly less bleeding risk associated with them down the road. So there's work going on in this space. We've communicated about this before. It's in the PEP library. So, read about it, or just, Google or chat GPT factor 11A and what the trials are ongoing, because there's hope for us that are taking anticoagulants that maybe we will have something down the road that won't have as much of a bleeding risk, which would be great.
Totally. I think it's an important point to bring up. And I think those drugs are on the market and there will be more. This is
Yeah.
a huge area. And so even if those aren't the perfect thing, there's going to be other options too.
Yeah.
So I think it's super important to bring up though.
Progress. Okay. Todd, bring us home.
Okay, so one final question. I'm going to ask it for two reasons. Number one of the registrants asked this, okay, when they signed up. And number two, this is one of the top 5, 6 questions that I've now seen in the support group for the past month. I don't know where this is all coming from, if there was a story about it or whatever, but how safe is it to use a vibration plate? You know what I'm talking about? The ones you stand on. And there's other ones.
Okay.
How safe is it to use that if
Mm.
you are on anticoagulants? Because I've seen a lot of our older patients where the doctor has recommended that they use a vibration plate. And other doctors are like, well, it depends on your clot status, how
Mhm.
easy you bleed and bruise. What's all that about? What's the vibration plate about, and can people use them safely?
Oh, I love this question. This actually gets back to a project we did with the National Blood Clot Alliance, which is basically about how there's so little consensus from doctors about like what physical
Yeah.
activity is safe and what's not.
Yes.
You ask a bunch, we surveyed like 140, I think, different providers. They all say different things
Right.
about what activities are safe and what they recommend, and they have very little confidence because honestly, we don't know. We don't know if a vibration plate is safe. What I always tell people is like, hey, you got to listen to your body. If you were running a marathon before this clot happened, then like you can probably start to do that when you feel comfortable doing it. And it may be helpful to you. And if you were doing a vibration plate, which I'll be totally honest, I don't know what that's for. But if you were used to doing that before, I think it's likely fine. You're on a blood thinner, so that's very protective. Like that's a key point is. But every kind of physical activity, especially ones that are high impact, like riding a bike or doing karate or whatever, comes with a potential bleeding risk, especially if you fall. So, but like I said, I think we were talking before this started, many people are taking these drugs for the rest of their life. So you have to live your life. You have to do the things that matter to you, the things that you care about. There are going to be some questions that we don't have science to tell us the answer. I think vibration plate may fall into that category. But what we can say is that there's a need for more consistent recommendations and guidelines about what kind of physical activity is safe. Because we've been talking about this the whole night. It's clearly really important. But providers need to have a consistent message so that it's not so confusing for people.
Yeah, and I'm not talking about being the subject of a knife thrower at a carnival or playing rugby where it's
No
concert
judgment. No
But you know
judgment.
what? If you rode a bike before you suffered a blood clot, now you're on blood thinners, to me, you can still ride a bike. It's like wear a helmet, take precautions. There's no reason why you can't, unless you have some physical limitation, why you can't do that activity and enjoy your life.
For some people that causes too much anxiety, and for other people,
Yeah.
it's like their mental health outlet is to exercise. And so
Yeah.
every person is different. So
Yep.
you gotta have a conversation and decide for yourself. But doctors can do a better job of like trying to have the best science that we can and have some consistency in our recommendations so you're not getting mixed messages.
Yeah.
Agreed.
Well,
Good
hopefully
point.
we're moving towards giving guidance, if not guidelines, some guidance around this very topic of exercise. Okay, so why don't we move to the exit poll questions? Which there we go.
Okay, here we go. First question, folks, if you could answer these real quick. After tonight's webinar, how confident are you in recognizing the signs of a blood clot? Very confident, somewhat confident, still not confident. What is one step you can take to lower your blood clot risk as you age? Make one of these choices. Stay active, discuss medication risks with my provider, know and monitor risk factors, or is it all of the above? And the final question, how likely are you to share what you learned tonight with friends and family and have a discussion, which I think is important? Very likely, somewhat likely, or not likely. And we'll read the results to you, and then we're going to close out our night. After tonight's webinar, how confident are you in recognizing the signs of a blood clot? Very confident, said 31. 64, kind of in the middle, somewhat confident, still not confident. 5% said that. What is one step you can take to lower your blood clot risk as you age? Stay active, 10%. Didn't see on the no results on the other two questions, or the all of above. That was 90%. That's why. So there's your answer on that. And how likely are you to share what you've learned tonight with maybe some of your friends and family? Very likely, 69%. Excellent. Somewhat likely, 22%. 9% not likely. And Leslie, I think that's sometimes because family doesn't listen to the patient sometimes. Sometimes it's not as easy as just sitting down and having a conversation. We see that in the support group all the time.
Well, that's why I talk to you all the time, because I know you listen.
Anytime.
On that note, Anna, thank you so much. This was wonderful. I really
Yeah,
enjoyed
thank
the
you.
conversation, and we have some additional homework to do, I think, for our community. And I think this trial information will also be really super interesting for people as well. So
Mhm.
have a great night, and we'll see you in September for our next PEP.